Hello everyone, I'm Dr. Priyanka Sharma, Assistant Professor, Banasi Das Chandiwala Institute of Physiotherapy. On behalf of BCIP, I would like to welcome you all to the Alumni Talk series. We are here to discuss physiotherapy management of COVID-19 in acute hospital settings, a holistic approach. Today with us we have renowned physiotherapist Dr. Stuti Malhotra. She is also BCIP 2007 batch alumni. Let's greet our panelists today. Thank you Dr. Stuti for joining us. Our guest Dr. Stuti Malhotra is currently working as a senior cardiovascular and renal physiotherapist with King's College Hospital, Brixton, London. She has a clinical experience of around 6 years in the field of spine, cardiac and renal rehabilitation of patients in community as well as in hospital settings. She has handled various positions as a consultant, clinical trainer and a team leader. She comes with the background of specializing in sports physiotherapy, making her skill set very diverse. She is very passionate learner and believes to deliver her best when it comes to treat and facilitate rehabilitation among patients. I appreciate on behalf of BCIP the admirable work of her done in the field of physiotherapy. Now I would like Dr. Stuti to take over the session and enlighten us with the physiotherapy management of COVID-19 in acute hospital settings.
Okay, so when are we going to get the vaccine? Very interesting question. I don't think more than 6 months. But how is the situation back in India? Is anyone getting anxious? Is there any problem? What's going on? The rates are increasing every day, all right. And so the rates are increasing. Also, I believe the norm of social distancing is disappearing. Very sad to know that roughly 4 lakh cases. All right. So as of now, India has still not achieved its peak in terms of what we have seen in United Kingdom, basically. And if social distancing is not being practiced, it's a bit sad thing to know that, because coronavirus can be controlled if it is contained properly. So let me proceed with my presentation. Okay, so SARS-CoV-2 says hello to the world, how it started. So severe acute respiratory syndrome, coronavirus 2, World Health Organization was informed of cases of pneumonia of unknown microbial etiology, which was associated with Wuhan city in Hubei province, China on 31st of December 2019. That's the reason why it has a number 19 behind it. Since then, this epidemic escalated rapidly, spread around the world with World Health Organization, and they declared it as a public health emergency of international concern on 30th of January 2020. That means it was more than a month coronavirus was creating all its panic since the emergency was concerned and was declared, and formally the pandemic was declared on 11th of March 2020, and the official name was given as Coronavirus Disease 2019, which we often say as COVID 2019.
Dr. Stuti, your screen sharing has stopped. Kindly restart it. Your screen
Sure,
is not visible.
Okay, I'll do it again. Okay, can you see now?
Yes, ma'am.
Okay. All right. So, so definition says that the clinical presentation is generally that of the respiratory infection with symptoms which are severe, ranging from mild common cold-like illness to severe viral pneumonia, which leads to acute respiratory distress syndrome. So it becomes very difficult to understand that whether I have a flu or I have a COVID, or whether I will progress, will I deteriorate, or what will happen to me. So characteristic symptoms includes fever, cough, dyspnea, and altered sense of smell or taste. So this symptom, which says altered sense of smell or taste, was not there before. But when we saw patients clinically, majority of them were complaining of that, and it was considered in a category that it is one of the peculiar symptoms. Complications of this disease are multi-organ failure, septic shock, blood clotting, respiratory failure, and less common symptoms, they are myalgia, fatigue, anorexia, chest tightness, gastrointestinal symptoms, dizziness, headache, neurological symptoms, hemoptysis. The list is not stopping here. It is still ongoing. Some neurological manifestations have been seen as well. Now we need to understand that all this group of symptoms is seen because this COVID-19 is not only present in your respiratory droplets, but once it's inside your body, it can go into your cerebrospinal fluid, your pericardial fluid. It can go into your placental fluid as well. So we can see multiple picture of the symptoms. And going ahead, so the management predominantly depends upon how severe is the disease, isolation at a suitable location, infection prevention, what control measures we are taking, what are the symptomatic management we are doing, how much supportive care is required, and how critically ill is your patient. So all this is going to predominantly give you an idea that how you are going to manage this disease. But before we go ahead for the management, we need to understand what are, when do we say that a patient is suspected, is confirmed of COVID-19? Are we doing enough testing in our country? If not, then what are the measures, how we can do that? So in terms of this, we need to understand, like coronavirus has specific symptoms, like it will give you fever, it will give you cough, it will be shortness of breath. You may have altered sense of smell or taste. Now, if a patient is asymptomatic and a patient is symptomatic, how you can differ between both of them, and people who are coming in contact with these patient groups, how you have to protect yourself and understand where these patients will go. So World Health Organization has given a classification which says mild COVID-19, moderate, severe, and critical. Depending upon their severity, they will be managed. Like a mild COVID-19 can be managed in a healthcare facility, community, or home isolation is absolutely okay. There is no problem. If you are asymptomatic, that means you just got your test positive, you were swabbed, you came out to be positive, but you are showing no symptoms, then also home isolation is perfect. You do not need any medical intervention. But if you have a moderate COVID-19, then a healthcare facility is a must. You can home isolate if you are a very low risk group or you are not at a risk of deterioration. But severe and critical COVID-19 cases will be managed only and only in healthcare facility. They cannot be managed at home. So to go ahead with management of mild COVID-19, so patients with suspected or confirmed mild disease, symptomatic patients which meet the case definition of COVID-19, that means they have fever, but they don't have any pneumonia or hypoxia, meaning shortness of breath, or any respiratory symptoms, or they can be asymptomatic. So they must follow the isolation. Location of care is mainly healthcare facility, community facility, or at home. And 2 negative test results are required before the patient is released out of the isolation. Now, what is an isolation? Isolation means that a patient who is having mild symptoms or asymptomatic is in his or her own bubble. So bubble means a home environment where the patient is living by himself. Like now in situations like in India, if you are asymptomatic or have mild symptoms, you are restricted in your room and your food, your water is being supplied out of the door. That is absolutely fine. But if you are isolating with probably one more member of your family, then you both are considered to be in the same danger zone as a symptomatic or asymptomatic patient is. Now, in terms of management of mild disease, I don't know how much testing is being done in India at present, but what statistics and what the media is saying, it's quite difficult to get yourself tested. So what you can rely on is how this disease is transmitted. If you are symptomatic, if person A is symptomatic, having fever, but doesn't have any other symptoms and was swabbed and he's positive, so he needs to self-isolate himself for at least 10 days after he had an onset of the symptom. And this will go on till 10 days, plus you have 3 consecutive days without fever and no respiratory symptom. Whereas if you are asymptomatic, but somehow you got yourself swabbed, maybe because someone in your family was positive, critically ill or severely ill, and they asked all of the family members to be swabbed, they got themselves positive and they are asymptomatic, they need to self-isolate for at least 10 days, 2 days before symptom onset and 14 days later. And after that, 10 days of strict isolation is recommended. And infection prevention and control wise, you need to follow all the PPE guidelines. If you are at home and there is a patient of mild COVID-19 in your home, you need to wear mask inside the house as well, and follow all the instructions given to you, follow all the guidelines given to you. The reason behind this, the transmission of this COVID-19 happens from person to person. It is a human to human transmission. The transmission happens only when you receive respiratory droplets when a person sneezes, coughs, or does any procedure where there is sputum coming out of the body. Then only the people who are in contact are at a risk of getting the infection. But otherwise, if your patient does not have any respiratory symptoms like coughing, sneezing, we still don't know whether the patient is transmitting the virus or not. Also, it depends how much viral load or viral shedding is happening. So when a patient is positive, then the viral load is quite high in the first, you can say, in the first week when he is symptoms. So in that case, it becomes quite important to know what is happening. And also, yeah, so let's go ahead. Okay, so symptoms, mild disease, fever and pain, paracetamol and ibuprofen, perfect to go on. We still don't know whether how much efficient they are, but we are just managing the symptoms. We don't know, there is no evidence of taking NSAIDs such as ibuprofen in terms of how much it is helping to control the quality of life with COVID-19. So it's just a symptomatic treatment. Cough. So for cough, you need to avoid lying on your back and use simple measures to help cough, like a teaspoon of honey or the cough syrups. But if you develop the olfactory dysfunction, then need not to worry. It comes back when the virus is going out. But if not, and if it's persisting more than 2 weeks, then you need olfactory training to get rid of it. Now,
Dr. Stuti, your screen is not visible.
The screen has gone again. Just a second. Yeah, is it visible now?
Yes, it is.
Okay. Let me go a bit back. Yeah. So apart from managing the symptoms of mild COVID-19, supportive care is very, very important. Adequate nutrition, rehydration is very, very important. But too much fluid can worsen the oxygenation. So here we need to be a bit cautious about patients who are having kidney diseases, heart problems, elderly patients. Like, do not tell them to drink lots of fluid, because it can accommodate in your lungs and may hamper your breathing. Improve air circulation in the surroundings, like keep your house or keep the area very, very well ventilated. Mental health and psychological support is very important. I have seen patients back in India. I have spoken to them where they came out to be positive. They are not exhibiting any symptoms. They are asymptomatic. And then one fine day, ambulance came and they took them to a community healthcare facility where they were admitted for 10, 14 days. They're literally crying on the phone in terms of what's happened to me. Will I die? Will I deteriorate? Will I survive? So a lot of counseling is required. So at this stage, we being a part of the healthcare system, it's very, very important to keep ourselves updated regarding what's going on. And if you are mild symptom category and you are not deteriorating, there is nothing to worry. You just need to self-isolate yourself, manage your symptoms, and you will be fine. And preventive measures like hand hygiene is very important, which says you have to wash your hands at least for 20 seconds. So there are a lot of guidance about how you need to wash your hand, how you need to washing hands from at the back side, at the front, between the web areas, using your thumbs, everything, because the hand contamination is one of the area which is transmitting the virus quite a lot. So this virus can survive on a hard surface for up to 24 hours. Like if you are in a hospital, you are touching this pen or using your mobile phone, and if you just treated a COVID patient, you don't know from your hand, you are giving the virus to this pen. On plastics and on stainless steel, the virus can survive for up to 72 hours. On soft surfaces like your clothes, the virus can survive up to 8 hours. In fact, on your mask as well. And on cardboard, like your folders or your wooden furniture, the virus can survive up to 4 hours. So it's very, very important to disinfect. Don't use your hands over your face, adjusting your mask, adjusting your PPE, stuff like that. Face covering, again, very, very important. So there are also a lot of questions and curiosity about the type of face covering one should use. It's absolutely fine to use your own handmade or homemade protective face covering over your face, provided you are washing it on daily basis. Surgical masks are absolutely fine to use when you are not coming in contact with the COVID patient. But if you are in contact with the COVID patient, say somewhere up to 3 to 4 meters, you need to wear FPP3 mask or N95 mask, which is very, very important. Your face coverings are very, very important. Screening and quarantine. So screening means quickly taking up the patients, quickly diagnosing the patients, and then quarantining themselves, self-isolating themselves. Social distancing, again, is very, very important because the transmission is human to human. We don't know whether you are asymptomatic and still you are transmitting the virus, because the viral load is quite high when you are asymptomatic. So it becomes very, very important. So avoid public transport when it is crowded, so you can change your work hours. So all the managers should be, I think, should be very, very accommodating, should be very, very flexible in this regard. Like having online lectures, do whatever you can do from social distancing perspective. Even in the classroom setting, it is quite important to break the large classroom number size to small groups if it requires something to be done very practically. If not, then whatever you are doing using the online resources is appreciated and should be continued. Shielding and vulnerable people. Now, a very important point here is this COVID-19, it binds in your body, but where it binds. it binds to angiotensin converting enzyme receptors, ACE2 receptors. So wherever these receptors are, it is going to bind to that particular area, and it's going to work there. So like lungs, your kidney, your heart, your ileum, so they become quite, you can say, a potent organs where this virus is going to go and attack. So shielding means patients who have underlying health disease like kidney problems, heart failures, patients who are on hypertensive medications, patients who have gastrointestinal problems, they should be shielded. Shielded means do not come out of your house, try to stay inside, and you need to follow all the preventive measures. Immunity passport is practiced in certain countries now. It's like, if I'm infected with COVID-19, automatically my body is going to produce some antibodies. These antibodies are going to help fight my body. So my antibody test is going to be done, and if I come positive with antibodies, I will get an immunity passport that I am immunized. I have immunity against this problem. But we still don't know for how long you are protected, and after how many days you get these antibodies in your body. It's certain research has said that once you get infected, after 2 to 3 weeks, your body is generating the antibodies, but we don't know for how long they are and how well protective they are. And smoking cessation, please do not smoke, because smoking is again going to be very, very harmful for your lungs. So lungs will become again a very potent organ to get this disease back. All right, so I'm just welcoming all the questions. Until now, if you have, please hit me with the questions. Until this level, what do you think, you being a physiotherapist, can manage the situation? Do you think you have a role as of now treating mild diseases? I'm happy to read in the chat, or if you can unmute yourself. Yeah, anyone wants to answer this question? What is the role as of now? So until managing mild symptoms, what you feel, you being a physical therapist, can do? So Salma says yes, definitely. All right. Anyone else who wants to say? So Gunjan says yes. Yes, can counsel the patient. So you can counsel the patient. Yes, definitely. But in this case, you should be aware how you can help them in terms of supportive care, in terms of managing their anxiety, in terms of managing their confusion, in terms of answering their question. Ma'am, can you please repeat medication you tell? So the medication here is managing your symptoms like fever. So for fever, we take paracetamol. That's perfectly fine. Low dosage as per the tolerance of the patient is absolutely fine until the symptoms are getting under control. Like today, if I get symptoms, just a fever, but I don't have any cough, I can take a paracetamol, start self-isolating myself. If I am not swabbed, no problem. Just manage your symptoms, just monitor yourself. If you're not getting deteriorated, absolutely fine. Breathing exercises, yes, they are helpful. But in mild cases, there is no evidence. But with severe and critical cases, yes, they do help. What would be benefit of an immunity passport? So immunity passport is practiced somewhere in UK, in Australia. Not sure if it's practiced in India. So it's like you are getting a passport, you are getting a certificate that you have antibodies in your body. Antibodies means you have your self mechanism to protect against COVID-19. For example, if I have coronavirus and after 15 days, I am all clear, I don't have any disease, I am swab negative. And after 15 days, I am coming again in contact with a patient or anyone who has COVID-19, I have antibodies, I need not to worry. So this is quite important for your healthcare workers, people who are coming in contact, but still lots of countries and WHO is not in favor of promoting this immunity passport services. All right. Okay, so anyone has any further questions? When should PCR testing be done and when should rapid testing be done for the diagnosis? So PCR testing, a very good question. So a PCR testing is done when you have symptoms like fever, cough, shortness of breath. You should not miss your PCR testing in this scenario. If you are not getting PCR testing done, then kindly self-isolate and manage your symptoms. But once you are in a healthcare facility like a hospital setting, they are definitely going to do your COVID test before they are going to start any treatment apart from the symptomatic management. All right, so any questions or shall I go ahead? All okay to go ahead?
Yes, Dr. Stuti. You may proceed
All
further. We'll take up the questions in the end.
Sure, okay. Just a second. Okay, so now management of COVID-19 moderate cases. Just a second. So moderate cases means like now I have fever, but I have clinical signs of hypoxia, shortness of and oxygen requirements. I'm having shortness of breath, but it's very important to understand shortness of breath on exertion or shortness of breath at rest. Everyone will be having shortness of breath when they are exerting. Doesn't mean you have COVID-19. But if you are experiencing shortness of breath at rest or at activities where you are not short of breath before, then it's a matter of suspicion. When it's a non-productive cough or patient is coughing and able to clear secretions independently, so it's again a moderate scenario. All these patients, they are managed in healthcare facility, community, home. Telemedicine or remote consultations are very important for such patients. After that, monitoring comes very, very important because you need to monitor them, track their deterioration, whether they are getting any further symptoms or how they are managing. Now, with such patients, one can discontinue transmission-based precautions or isolation after 10 days after the symptom onset. For example, today is 20th of June and I have fever. I have some shortness of breath and some cough. Today is day 1 where I am reporting the symptoms. I am going to self-isolate myself for next 14 days and I can relieve the restrictions 10 days after the symptoms. Plus, I should have at least 3 days when I do not have any fever and respiratory symptoms. This clinical picture will tell that I am getting better of COVID-19, which was moderate in nature, unless of getting me swabbed or retested again. If I'm getting myself retested well enough, if not, then I can rely on this clinical presentation. Now, symptom wise, again, you have to manage symptomatically, but antibiotics are given if there is suspicion of bacterial infection. And this becomes quite important with firing her. And next day she developed diarrhea. So she will need antibiotics to manage her diarrhea, but not necessarily for the COVID. Same goes for the children, but likelihood of children getting affected with COVID-19 is very, very less as compared to age group more than 30 years. Then monitor very closely for signs and symptoms of disease progression. Counsel patients regarding their signs, their symptoms, and if you think they are getting deteriorated, then they need to be taken to hospital settings for further management. Also, I am seeing quite a bit on social media and Facebook, like people are promoting use of pulse oximeter. in home settings to see how much oxygen saturation, like put the oximeter on your finger and it's 95, I'm fine, there's no problem. So clinically, there is no evidence of using pulse oximeter in home setting. What you need to rely is on the symptomatic presentation of the patient, the clinical presentation of the patient, how much shortness of breath he or she is getting. You may see saturation dropping to 85, 88%, but patient is absolutely fine. There is no complaint of shortness of breath. Or you may see saturation up to 90, 92%, but the patient is very, very short of breath. So it rely on clinical presentation more rather than testing with oximeters and testing with your thermometers and stuff like that. Now for moderate disease, do you think we need a physiotherapy referral? Physiotherapy referral is required until we need airway clearance. Like if we have coexisting respiratory problems like neuromuscular comorbidity, cystic fibrosis, spinal cord injury, bronchitis, COPD, only then we need PT reference. Otherwise, encourage patient more to clear their secretions by themselves. Evidence of exudate consolidation, difficulty in clearing or inability to clear secretions, like weak, ineffective cough, then we need physical therapy. Otherwise, encourage them to do by themselves. So there is a debate going on in terms of aerosol generating procedures. So cough, like when we ask someone to cough, is considered as an aerosol generating procedure. When we do any of our PT, chest physiotherapy is an aerosol generating procedure. Giving non-invasive ventilation, going for CPAP, BiPAP, going for your any ACBT techniques. So wherever you are asking a patient to do a cough or intubation, extubation, they all are considered aerosol generating procedures. So these procedures are giving you very high risk of getting infected. So if a physiotherapist is getting involved, then please make sure you are wearing protective equipment, PPE, which is very, very important. If not, try to be out of doing any of the aerosol generating procedures until it's very, very necessary. Like if patient is desaturating a lot, chest physical therapy is indicated, you need to do it, then you need to wear protective equipment before you do it, because you are increasing the risk of infection. The infection or the respiratory droplets are going to be in the environment, and whenever you are doing it, you need to do it in an isolated room or a room which has a negative pressure. All right, so I go ahead now. Now, before I go ahead to severe and critical management, all the students need to revise their assessment, and you should be very, very clear about how you do a chest assessment, how you do a neurological assessment, how you do your musculoskeletal assessment. So for your assessment, I will be very, very precise here because I cannot cover this. So follow A to E method, airway, like whenever you're going to see a patient, airway, see whether the patient is intubated, there is tracheostomy being done, is the airway patent or the patient is on ventilation. B for breathing, check how the patient is breathing. Are they on any oxygen support, or check their interface X-rays, ABG reports, SpO2, respiratory rate, check for their cuff, sputum, palpation. You need to check all this. Cardiovascularly, you need to check their vitals, heart rate, blood pressure, ECG, temperature, bloods. So in bloods, it's very, very important to check this. Let's go back again. So yeah, assessment wise, so cardiovascular, disability and exposures to environment. So that means you need to be on top of your assessment whenever you are going to treat a critical or a severe COVID-19 patient. You can follow the A to E method in your head quickly. It is very, very good and practical approach to done when you are treating a patient, or you can follow a system approach. So a system approach says that you can do neuro assessment, see if appropriate, cardiovascular, respiratory, bloods, or observation whenever they are appropriate. Just put tick, tick, tick in your head and elaborate if it's required further. Now, severe COVID-19 patients which are suspected or confirmed disease and they are at a risk of rapid clinical deterioration. So that means they have fever, they have cough, they have shortness of breath, their respiratory rate is more than 30 breaths per minute, they have severe respiratory distress and they are unable to maintain their oxygen saturation less than 90% on room air, which means they need oxygen now. Oxygen therapy is important. In children, again, if there is central cyanosis, that means unable to maintain their oxygen saturation, they are unable to breastfeed, drink, unconscious, getting convulsions, or if there is any severe respiratory distress. Now, for such patients, very, very important to get them swabbed. And in the hospital settings, they will be swabbed on the admission, number one thing to be done. So again, you have to follow 10 days after symptoms onset plus at least 3 days without fever and respiratory symptoms once you release their isolation things. But hospital is going to take over and they are not going to be in the community anymore. So oxygen, very, very important. So supplement oxygen needs to be started. Emergency signs you need to maintain and see. Saturation needs to be more than 90%, but with older population and with children, the respiratory consultant is going to set their oxygen saturation. So sometimes you will see that they have oxygen saturation advisable somewhere from 92 to 94 or 88 to 92. For such patients, you need to follow what they are saying you at that time. Also, consider positioning techniques in terms of physiotherapy, like airway clearance, like high supported sitting, prone positioning. So prone positioning in practical perspective is very, very difficult to do because patients is connected with lots of lines, oxygen support. So it's quite difficult to practice, but physical therapists can definitely consider about positioning. And you need to monitor them from hypoxic respiratory failure. And patients who continue to deteriorate, they need more oxygen requirement or may need a ventilatory support. Again, symptom-wise, you are going to manage them symptomatically, but you can see two more additional things here, fluid and electrolyte, anxiety, delirium, and agitation. So this is a very tricky virus. We have seen patients getting a lot of anxiety. They are very delirious and they are very, very much agitated. So behavior change is very, very common to see when they are severe to critically ill. They are very, very delirious. They do not respond to, they are not oriented to time, date, location. They may not know your name. So no need to worry. They will come back, just they need is time. Fluid and electrolytes is very, very important because patients with cardiac ailments, renal diseases, do not encourage them to drink lots of fluid because that can cause overloading, hyperglycemia, metabolic acidosis. So you need to manage these things quite precisely with the consultant. Unnecessary physically challenging them is not appropriate at this time. Also, COVID-19 is giving issues like pulmonary embolism or VTE. So venous thromboembolism prophylaxis, VTE, is very, very important to be administered. So you will see patients with are on heparin, warfarin when they are admitted because this disease can cause blood clots in your body, can cause embolism. So we need to treat that as well. You being a physical therapist need to ensure that patient is not having any DVT or is not having pulmonary embolism because pulmonary embolism and chest physiotherapy, they don't go hand in hand. They can kill the patient. After that, severe COVID-19 patients, we need to go for antimicrobials. Like if we have any suspicions of bacterial infection, go on for the antimicrobials, but there is no evidence which says that antimicrobials is helping to treat COVID-19. We just need to do it symptomatic management. Once patient is stable clinically, then we can consider discharge and rehabilitation. So discharge, like patient is here, 75-year-old female in hospital, severely ill, clinically stable now, medically fit to discharge, is going home. The lady is going to self-isolate herself for another 10 days or the days when 10 days plus when she is having 3 days of no symptoms, no respiratory disease. After that, she is free to go out in community with the face coverings, with all the PPE guidelines and social distancing guidelines and stuff like that. And monitor patients very closely when they are severely ill, and also review them for their mobility, functional swallowing, cognitive impairment, mental health concerns, because at the moment we don't know, like if you are having severe COVID-19, will you get it again, or you will not get it? Will you recover? Will you not recover? Will you die? What's going to happen? So you just need to counsel the patient, monitor their symptoms. Also, some therapies like remdesivir, hydrochloroquine, leponavir, so all these are antiviral drugs. There is no evidence in terms of how much they are helping the patients as of now. We still need to run clinical trials. Now let's come to the critical COVID-19. So these patients are managed in intensive care, critical care unit. And being a physiotherapist, you will be involved only if they need a chest physiotherapy. But again, you are not going to do any procedure which is aerosol generating, which means that patient is asked to cough, or you are breaking the ventilator circuit and maybe making the environment more infective. You will only do it whether it's a high need and you are doing it in a negative pressure area, and the patient is in isolation inside the ITU, and you need to be in your PPE, which is very, very must. That's the reason why high flow nasal oxygen or non-invasive ventilation is not appropriate in COVID-19 patients. We are not seeing clinically that they are fit enough to manage with their hypoxia. If the patient is in ICU, they are intubated, they are put on mechanical ventilators straight away. But some areas clinically, they are using CPAP, which is bridging the time for them to go over to invasive mechanical ventilation. But apart from that, when the patient's chest is getting more affected, apart from that, we have to manage it very holistically in terms of what's happening to the patient. In ICU, patient is not only exhibiting chest symptoms, but patient is giving you a multiple presentation. Patient is delirious, patient is not oriented, cognitive failure is there. So with such patients, non-invasive ventilation is not going to work. Also, nebulization, suctioning is not appropriate with COVID-19 patients when they are critically ill. A strong support for the critical management with mechanical ventilation is required. And spirometry, again, we don't have any evidence of incentive spirometry with COVID-19, but with mild to moderate patients, we can do that. A chest physiotherapist cannot work on inspiratory muscle in the ICU setting when the patient is on mechanical ventilation or if the patient is desaturating. That is not going to work. So with this regard, we strictly need to pick up our tools, which we are going to use in terms of chest in ICU settings with the patient. I think there are a couple of questions. Let me have a look if there is anything. All right. How effective is plasma therapy? How do negative pressure help prevent? So, okay. And all right. So I will take all these questions at the end of the presentation because some of them will be answered very, very soon. Okay. So mechanical ventilation, I have talked about that, which means endotracheal intubation, which will work. So the statistics wise, 2/3 of patients in United Kingdom were straight away gone to mechanical ventilation within 24 hours, which says that it's a high dependency. And male patients, obese patients, patients with elevated inflammatory markers, liver function test, they usually spend around 18 days on ventilator, roughly around 9 to 28 days. I have seen practically patients spending around 2 months also on ventilator and then getting stepped down to the wards. So this is a tricky virus. We don't know how it behaves. Sometimes patients recover, sometimes they don't recover as well. But we need to follow what we need to follow: symptom management and supportive care, which is the holistic approach. And we may go, or consultants may choose to go for palliative care, which is like advanced care planned for end of life when the patient is not responding on the mechanical ventilation more than 2 months. You being a physiotherapist, what you have to do is airway clearance technique, but do not encourage aerosol generating procedures. Techniques to facilitate secretion clearance like cuff maneuvers, airway suctioning, and exercise prescription and mobilization. All right, let me see if there is any appropriate question to be taken now. Is there any variation in virus structure in different countries or condition? This is a very good question by Aditya. So Aditya, definitely yes. So geographically, guidelines are different. For example, previously it was said that this virus is more contagious in cold countries where the temperature is low, and in warm countries, this virus is not going to survive. But still research is going on, we still don't know. But definitely geographical conditions and ethnicity, like Black people, Asian people, they are more prone to get this coronavirus as compared to white. If anyone having high blood pressure, if he or she at any risk of COVID infection, definitely yes. So high blood pressure is going to put a lot of demand on your cardiovascular structures. Also, high blood pressure patients, they are on medications which are again modulating your ACE2 receptors, which is like a hot cake for your virus to attack on. So there are research and published articles which says that patients who are having high blood pressure, they are more prone to get COVID infection. What will be the management of COVID-19 in home isolation instead of PCM and ibuprofen? In home isolation, just monitor your symptoms, very closely monitor your symptoms, just symptomatic treatment, self-isolate, spend time on Netflix, do whatever you want to do, but inside your home, but do not exert. That's what you can do when you are at home. All right, recommendations for physiotherapy, respiratory intervention. So now I am shifting myself from management to the recommendations. So the management part is over. Now the recommendation part says PPE, strict donning and doffing of PPE is very important when you are in the close vicinity of the patient. Close vicinity means less than 1 meter for more than 15 minutes. Cough etiquette, ask the patient to turn your head away when you are coughing, and patients who are able to catch their cough with tissues, promote them. Otherwise, PT should position themselves more than 2 meters away from the patient if possible, until and unless you're doing anything with your hands. Aerosol generating procedures, like many respiratory interventions, they are aerosol generating procedures. If required, carry out in a negative pressure room or in a single room with your door closed. Spirometry recommendation says we have no evidence as of now. Sputum sample, if patient is productive of sputum, PT intervention is honestly not required. If patient is not doing that, PT intervention is required to facilitate a sputum sample, but then PPE guidelines should be taken into consideration and safe transportation of sample to labs should be done. Then saline nebulization and manual hyperinflation is not recommended. However, some countries have different guidelines. It varies from country to country. You need to stick what India is doing as of now, but do keep in mind what is going on in the world as well. Gravity assisted drainage, yes, you can position the patient to aid drainage. Prone positioning, very, very difficult to practice in ICU settings, in the ward settings, but do liaise with your nurse in charge and the consultants if they are quite keen to practice this. I haven't done any prone positioning and I haven't seen any of the patient being promoted, being encouraged to do that. Tracheostomy management wise, you should always follow a close inline suctioning. And inspiratory muscle training, everything can be done later when the patient is going on for the rehab. Physical therapist, in terms of chest point of view, really need to select your tools, what you need to do, what you are not going to do, because the main thing you need to take care is do not promote any aerosol generating procedure. Now, once your patient is out from the ICU, the patient is usually shifted to a ward um, where we need to focus on mobilization, exercises, and further rehabilitation. So in ICU and CCU, you can practice some positioning, some shortness of some sitting out edge of the bed exercises, sit to stand, some sitting out in chair. But honestly, apart from positioning and sitting out the patient, nothing else is achieved because the patient is so delirious, is in a very confused state of mind. We cannot achieve other things. But once the patient is stepped down to the ward, early mobilization is preferred. So you can use walking Zimmer frame, stick, crutches. Cara Steady and Hoist are the equipments which we use here in London. So they are the very well structured equipments which a patient used to stand up from the bed edge, and they are hoisted in terms, they are just looped into a sling, taken up from the bed and put down on the chair. Very, very good equipment. I haven't seen them in India, but here, yes. So mobilization is very, very important. In community settings, you have to go for community referrals, bed-based rehab. So for example, a patient is medically fit to get discharged, but not very much confident enough to go to his home, do his activities, because this is a virus where a lot of your family will be very, very hesitant to help you. So you have to be on your feet, you have to be on your balance, you have to be on your strength. But at the same time, you are not fit to be in the hospital because you are at risk of getting other infection. So here in London, they have rehabilitation centers, which are like nursing homes, like a hospital where the patient goes, get themselves rehabilitated, like a very extensive physiotherapy is done, and they are sent back to their home. So it's a bridge between home and a hospital, bridge between a home and a critical care. But if it is lacking in India, preferably advise patient to be on their feet and get back onto their strength before they are getting discharged from the hospital. Specialized therapies like cognitive therapy, speech therapy, functional review, everything can be taken care of once the patient is COVID negative, swabbed again, and is not transmitting any virus further. Also, post-viral fatigue is very, very common in such patients, which we need to consider. PPE recommendations for physiotherapists. So donning and doffing, that means you have to wear full sleeve gowns, you have to wear mask, you have to put on a visor, you have to put on a hair cap before you step into a critical or a severely ill COVID patient. Fit testing means the mask which you use, it has to be tested first on you. That means they will do a test where they will push like a bitter or a sweet solution into a hood which you are wearing, and they will see whether you can taste the solution or not, and they will ask you to do a couple of head movements, maneuvers, just to check that you are tested enough for the mask. I can show you, so once I'll stop my screen sharing, I can show you some different masks I have with me. Then all your personal belongings like mobile phone, watch, earring, pens, everything should be out. Sanitize your hand, equipment, whatever you are using with the patient. For example, I'm using a walker with the patient in ICU. Before I take it to another patient, I need to desanitize the walker. So I can't just randomly take it to another patient. I need to desanitize my pen. So I always desanitize my pen. I desanitize my mobile phone whenever I am coming out of the ward before coming back to home. If preferable, use hospital scrubs or hospital uniform when you are treating these ill patients. And facial hair, in terms of having beard, in terms of having your hair on your head, just they need to be out, because all your facial hairs, men with beard and mustaches, they are going to hamper with your mask. So you will not be able, the mask is not going to be snug enough, and the virus can go in and you can get affected. So, all right. So one small question here. You all can see a small picture of me on the right side of the presentation. Can anyone spot missing PPE here? So what PPE I am missing here?
Head cover, hair cover.
Very good. Head cover is not there. What else is not there? Hair scrub, hair cap, yes. Hair cap. What else is not there? Very, very important. I'm wearing a mask. So this mask I'm wearing is a 3M mask. And I'm wearing a visor. I'm wearing uniform scrub, gown. So gown and head cover is absent. Very good. I can see a couple of questions and I will take them just in a minute. All right. So, okay. So yeah, so now I'm open for questions. And before that, it's my small picture from the ward when I am there. I am still wearing this when I am treating my patients with coronavirus. So what I'll do now is I'll stop my screen sharing and I'll go onto the chat and see if I can answer all your questions. Is that okay with everyone? All right. So
Yes, Dr. Suti.
okay. So question wise, I have answered this one. So 2 more messages. Okay. So now if I go further up, why nebulization is not recommended though it clears the airway? So nebulization is not recommended because nebulization is going to clear the airway, but with that, the vapors which are going to come up are going to be infected vapors. So they are going to be a risk. You are increasing the risk of others getting the infection. Nebulization is fine if you're doing in a negative pressure room or in a isolated room. It's absolutely fine to do that. But not done. But again, country to country, the guidelines are different. So follow what the guidelines are saying. Anyone having high BP, I have answered. Is there any variation in virus structure? No, there is no variation in the virus structure. The virus is same, but geographical conditions, the weather and your ethnicity, your risk factors like being a male, being obese, being any underlying health conditions are going to get you more prone to this virus. How does negative pressure help preventing the spread? So negative pressure takes away all the, so it works like a suction. So it takes away all the air which is there in the room, and from the other side it keeps getting supplied with the fresh air which is there. Can I catch the virus from being in an enclosed space in close proximity to someone who does not have respiratory syndrome? Nitya, very, very good question. WHO was honestly fighting 2 days ago onto this question. But if a patient is not having respiratory symptoms, the patient is either a mild category or is either asymptomatic, or the patient is like free from virus. So at the moment, it is very, very difficult for us to say whether you will get the virus or not. If the patient has no respiratory symptoms, very, very unlikely that you will get the virus because the patient is not giving any respiratory droplets. But again, if the patient is asymptomatic, does not have respiratory symptoms, and you are in an enclosed space, the viral loading is still there. So it's a gray picture. The answer to this question is neither yes nor no, but it's a gray answer. We don't know what is going to happen, but risk is less, but still risk is there. That is why you need to maintain social distancing. That is why you need to wear your mask covers and preferably be a little bit distant from each other. Yeah, any questions?
Thank you, Dr. Stuti.
Yeah. I have few masks to show you guys. If you can see me, I can show you some masks to you. Am I visible?
Yes, Dr. Stuti, you are.
All right. So you can see this mask. So this is a 3M mask, which does not have any walls. So you can't see any opening. So you open up this mask like this and you have 2 bands with it. So this area goes back to your chin and this with a small covering hair goes to your nose. So if you have facial hairs, your facial hairs can restrict and will not give you full support. So you have to just keep your two fingers like this, put it here, and you just need to keep it here and take it up and just snug it very precisely over to your nose and then blow air and check whether the air is coming out. And this is how you need to wear a mask. So you can see there is no air which can go in from here or which can go even from here. But the disadvantage with this mask is that it does not have any walls. So for me being a therapist, it is very difficult to wear this mask because what I am exhaling is what I am inhaling. And you need to change this after every 4 hours. You can't wear this whole day. So each mask needs to go in bin after 4 hours because the moisture is again a place for the virus to grow and contaminate. Apart from that, this is a surgical mask which has a thin wire over here, which we all use. This mask is perfectly fine to use in public areas. And you can just put it like this, keep it on your ear, and then just snug it on your nose here. With this mask, you cannot use this when you are treating a COVID patient or you are in close vicinity, say somewhere near 2 meters. This mask will not work. You can wear this in hospitals, you can wear this in public areas, you can wear this wherever you want, but not with the COVID patient. Another kind of mask is FPP3. So this, you can see a small valve over here. So this is a good mask, which will help me to breathe as well. Good for therapists, good for patients. Again, it is wear the same as a 3M mask, has a small foam which will cover my nose, and this will go up to my chin, and the elastics which I have to keep up over my head. So these are the different variations, different masks, different manufacturers are present all over the world. So you need to follow the guidelines and you need to see what is appropriate for yourself because your safety is going to be first. There is no point you getting infected being a healthcare worker, no matter if you are asymptomatic and then you are spreading the virus, because we don't know whether you are spreading, not spreading, what's happening, but still you are at a risk. Any further questions? Yeah, I'm happy to answer any further question if you have.
Dr. Stuti, I would like to ask one question.
Yeah, please go ahead.
One personal question rather. So besides that, DCIP helped you to develop the overall personality?
Definitely, yes. If I see I completed my bachelor's in 2012, and from there my journey began to a professional world. So BCIP definitely yes. All thanks to my teachers, my mentors, who takes so much of effort delivering the concepts, delivering good knowledge, because if that's not there, that confidence is not going to come. If confidence is not going to come, then your personality cannot be developed. So I would say personality, confidence, education, knowledge. So they all are very, very well connected. So definitely, yes, BCIP has laid foundation to where I am today. I'm very, very thankful to the institute, to my teachers, and I wish to visit Banarsi Das Chandiwala Institute very soon whenever I'm going to come to India. I don't know when, whenever the relaxation are there for travel. At the same time, very worried about India as well because the numbers are still going high. So all the best, stay safe and take care of yourself and no need to panic. The good thing about this virus is that recovery rate is good. Number of deaths is not as high as it was seen with Ebola, with SARS. So no problem, just stay safe and keep yourself very, very updated. Couple of questions more. How can we clear our airway with mild symptoms at home? So just you can do your active cough and that's going to clear very with the air, that you will not get the sputum. And also this virus has a dry cough. You will not generate cough. It's a dry cough, so nothing is going to happen. So no need to worry with the mild symptoms, but the risk of transmission is very, very high with this virus. It travels very, very fast, but at the same time, the death rate is not as high as it is seen with the other COVID viruses. Any other question you guys want to ask? With community, be very, very careful. For example, physiotherapists who are going to clinics, working in a home visit setting, very, very important to keep yourself protected. So encourage face masks, face covering, social distancing. Wherever possible, offer virtual support to patients, but I think personally it's very difficult to offer physiotherapy virtually. But wherever possible, do that, keep yourself safe, and hit me if you have any further questions to ask. What is infectious period of COVID? It is different from incubation period. Okay, very good question. I missed upon that. So incubation period of coronavirus is 1 to 14 days. Infectious period is, for example, I on 20th of June presenting with fever and cough. So I am spreading the disease 2 days before the onset of symptom. That means 18th June onwards, I was transmitting this virus, and I will keep on transmitting this virus until 14 days of my onset of symptom. That is until 4th of July. So 18th June to 4th of July, I am spreading the virus. So beware of me. That's how we need to figure out the window. But yes, onset of symptoms, very, very important, 2 days before and 14 days after. Are symptomatic patients at any risk? You need to monitor their symptoms. The risk will increase if the symptom is getting more and more severe. Asymptomatic patients will present with symptoms if they are getting worse. If not, then you may not know you have COVID and you were absolutely fine. And I honestly worked with COVID patients for 3 months, and I'm still treating COVID patients. I got my antibody test, and surprisingly it came out to be negative. So I don't know whether I got COVID, I did not get COVID, maybe I got COVID, I had antibodies, now antibodies are clear of my body, so we don't know. Lots of research is needed. So how long do the family members need to be in quarantine in case of home quarantine?
Dr. Stuti, it will be your last question. We'll have to conclude.
All right. So just this question, because this is quite important. So follow what India is saying you in terms of home quarantine. But if you have symptoms, then quarantine for 14 days is very, very important, unless you are symptom free for 3 days. And if not, then you have to follow what the guidelines are saying. Patient is having dry cough, then how can his chest mobilize? So chest mobilization techniques are there. This will give you chest secretions which are not COVID related, but maybe ICU or prolonged illness is giving you the secretions there. You need to go on. Is it possible that person has no other symptoms, but it's not only? No, that's not possible. So only change in smell and taste, but no fever, no cough, very unlikely. You may be very mild or maybe asymptomatic, but fever is very, very important because it's an infection. All right, so I would like to conclude here. If you have any further questions or you need any assistance from me, anything in terms of the guidance, Dr. Savita, Dr. Priyanka, they have my email ID. Please hit me on my email. I will be happy to answer you on the email. If you need any further topic to be covered on the COVID, I'm happy to take another webinar whenever you guys have time and whenever the institute allows. So let's see. If you need me further, I hope the situation gets better soon back in India and I can visit you guys soon. Thank you so much. Sure. It was an absolutely pleasure. Thank you all.
Dr. Stuti, it was quite an elaborative and exemplary explanation.
Yeah.
It was quite interactive. It was such a pleasure having you as a resource person over here.
Thank you so
On
much.
behalf of BCIP, I would like to thank you once again for enlightening us and making us more knowledgeable and ready to fight up with the disease.
Most welcome. Together we all can win, definitely. We don't know this virus, but we all can win over it. So don't worry.
Thank you, Stuti. Thank you so much for joining us.
Most
Thank you.
welcome. Most welcome. All right. So taking a leave now. Goodbye, everyone.
Bye.
Thank you, all the viewers. Bye-bye.
Hello everyone, I'm Dr. Priyanka Sharma, Assistant Professor, Banarsi Das Chandiwala Institute of Physiotherapy. On behalf of BCIP, I would like to welcome you all to the Alumni Talk series. We are here to discuss physiotherapy management of COVID-19 in acute hospital settings, a holistic approach. Today with us, we have renowned physiotherapist Dr. Stuti Malhotra. She is also BCIP 2007 batch alumni. Let's greet our panelists today. Thank you, Dr. Stuti, for joining us. Our guest, Dr. Stuti Malhotra, is currently working as a senior cardiovascular and renal physiotherapist with King's College Hospital, Brixton, London. She has a clinical experience of around 6 years in the field of spine, cardiac and renal rehabilitation of patients in community as well as in hospital settings. She has handled various positions as a consultant, clinical trainer and a team leader. She comes with the background of specializing in sports physiotherapy, making her skill set very diverse. She is very passionate learner and believes to deliver her best when it comes to treat and facilitate rehabilitation among patients. I appreciate on behalf of BCIP the admirable work of her done in the field of physiotherapy. Now I would like Dr. Stuti to take over the session and enlighten us with the physiotherapy management of COVID-19 in acute hospital settings.